Hello, welcome back to my channel. In this video, we will cover the malaria infection in detail. Malaria is caused by Plasmodium species. This is a protozoan parasite of red blood cells. In this picture, you can see a malaria parasite trying to attach and penetrate a red blood cell using its apical complex. Before proceeding further, let us revise the names of scientists who won Nobel Prize for their work on malaria. Ronald Ross identified the developing stages of malarial parasites in mosquitoes. Alfonso Leverin discovered the specific agent of malaria was in the red blood cells of a patient. Julius Wagner discovered the therapeutic value of malaria inoculation in the treatment of dementia paralytica. Yo-Yo Tu, a female scientist, discovered the anti-malarial drug artemisinin. Human malaria can be caused by 5 distinct species of Plasmodium genus: Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale, Plasmodium malariae, and Plasmodium knowlesi. Plasmodium knowlesi is a parasite of long-tailed macaque monkeys that can affect humans also. Malaria is a vector-borne disease. Human malaria is transmitted by over 60 species of female Anopheles mosquito. The male mosquito feeds exclusively on fruits and juices, but the female needs at least 2 blood meals before the first batch of eggs can be laid. Out of 45 species of Anopheles mosquito in India, only few are regarded as vectors of malaria. These are some of the commonly found Anopheles species. Malaria parasite needs 2 different hosts to complete its life cycle. Mosquitoes are the definitive host where sexual reproduction of Plasmodium species takes place, and humans are the intermediate hosts in which asexual multiplication occurs. Human cycle of malaria parasite is also called schizogony. Human infection comes through the bite of infective female Anopheles mosquito. Usually 10 to 15 sporozoids are injected at a time, but occasionally many hundreds may be introduced. The sporozoids are the infective form of malaria parasite that passes into the bloodstream, where many are destroyed by the phagocytes, but some reach the liver and enter the hepatocytes. Within an hour of being injected into the body, the sporozoids reach the liver to initiate the stage of schizogony or mirogony. The parasites multiply in the hepatocytes, producing mature liver schizonts that are spherical, multinucleate, and contain 2000 to 50,000 uninucleate merozoites. Liver schizonts rupture and releases merozoites in the circulation. These merozoites then enter the RBCs to begin erythrocytic schizogony. Erythrocytic stage. The merozoites released by pre-erythrocytic schizonts invade the RBCs in significant numbers, resulting in clinical disease. Merozoites are pear-shaped bodies about 1.5 micrometer in length, possessing an apical complex. In the erythrocyte, the merozoite loses its internal organelles and appear as a rounded body having a vacuole in the center with the cytoplasm pushed to the periphery and nucleus at one pole. These young parasites are therefore called the ringforms or young trophozoites. As the ringform develops, it enlarges in size, becoming irregular in shape and shows amoeboid motility. This is called the amoeboid form or late trophozoite form. When the amoeboid form reaches a certain stage of development, its nucleus starts dividing by mitosis, followed by a division of cytoplasm to produce mature schizonts or mirons. The parasite feeds on the hemoglobin of the erythrocyte. It does not metabolize hemoglobin completely and therefore leaves behind a hematine globin pigment called the malaria pigment or hemozoin pigment. A mature schizont contains 8 to 32 merozoites and hemozoin. The mature schizont bursts, releasing the merozoites into the circulation. The merozoites invade fresh erythrocytes, within which they go through the same process of development. This cycle of erythrocytic schizogony or mirogony is repeated sequentially, leading to progressive increase in the parasitemia. Latent stage. In Plasmodium vivax and Plasmodium ovale, two kinds of sporozoites are seen, some of which multiply inside the hepatic cells to form schizonts, and others persist and remain dormant in the resting phase. The resting forms are called hypnozoites, hypnos meaning sleep. From time to time, some hypnozoites are activated to become schizonts and release merozoites which go on infecting the RBCs. This is called a clinical relapse, and relapse of malaria is seen only with Plasmodium vivax and Plasmodium ovale that shows presence of hypnozoites. Whereas in Plasmodium falciparum and Plasmodium malariae, no hypnozoites are found. However, small numbers of erythrocytic parasites persist in the bloodstream, and in due course of time, they multiply to reach significant numbers, resulting in clinical disease. This phenomena is called recrudescence. The rupture of the mature schizont releases large quantities of pyrogens. This is responsible for the febrile paroxysms characterizing malaria. Schizonts rupture occurs every 48 hours for Plasmodium falciparum, Plasmodium vivax and Plasmodium ovale, producing fever every third day, also called tertian malaria, whereas it occurs every 72 hours for Plasmodium malariae, producing fever every fourth day, also called Quartan malaria. This chart shows various stages of the malaria cycle among different species of malaria. The first one is pre-erythrocytic stage. The pre-patent period is the time taken for the entry of sporozoites to the first appearance of malaria parasite in the peripheral blood. Erythrocytic cycle is the time from the entry of merozoite to the rupture of schizont. This table also shows the stages of RBCs affected with each species. Next is parasitemia per microliter. Then duration of fever, presence or absence of severe malaria, relapses and recurrences. Now coming to gametogony. After a few erythrocytic cycles, some of the merozoites that infect RBCs do not proceed to become trophozoites or schizonts, but instead develop into sexually differentiated forms, the gametocytes. They grow in size till they almost fill the RBCs, but the nucleus remains undivided. Development of gametocytes generally takes place within the internal organs, and only the mature forms appear in circulation. The mature gametocytes are round in shape except in Plasmodium falciparum, in which they are crescent shaped. In all species, the female gametocyte is larger, called as macrogametocyte, and has cytoplasm staining dark blue with a compact nucleus staining deep red. In the smaller male gametocyte, that is called microgametocyte, the cytoplasm stains pale blue or pink and the nucleus is larger, pale staining and diffuse. Pigment granules are prominent in this. Female gametocytes are generally more numerous than the male. Gametocyte appears in circulation 4 to 5 days after the first appearance of asexual form in case of Plasmodium vivax and 10 to 12 days in Plasmodium falciparum. A person with gametocytes in blood is a carrier or reservoir. The gametocytes do not cause any clinical illness in the host but are essential for transmission of infection to the mosquito. A gametocyte concentration of 12 or more per millimeter cube of blood in the human host is necessary for mosquitoes to become infected. The mosquito cycle or sporogony. When a female Anopheles mosquito ingests parasitized erythrocytes along with its blood meal, the asexual forms of malaria parasite are digested, but the gametocytes are set free in the midgut of mosquito and undergo further development. The nuclear material and cytoplasm of the male gametocytes divide to produce 8 microgametes with long, actively motile whip-like filaments, and this is called exflagellating of male gametocytes. At 25 degrees centigrade, the exflagellation is complete in 15 minutes for Plasmodium vivax and Plasmodium ovale, and within 15 to 30 minutes for Plasmodium falciparum. The female gametocyte does not divide but undergoes a process of maturation to become a female gamete or macrogamete. It is fertilized by one of the microgamete to produce the zygote. Fertilization occurs in 0.5 to 2 hours after the blood meal. The zygote, which is initially a motionless round body, gradually elongates and within 18 to 24 hours become a vermicular motile form with an apical complex anteriorly. This is called the hookinete. It penetrates the epithelial lining of the mosquito's stomach wall and comes to lie just beneath the basement membrane. It becomes rounded into a sphere with an elastic membrane. This stage is called oocyst, which is yet another multiplicatory phase within which numerous sporozoites are formed. The mature oocyst, which may be about 500 micrometer in size, bulges into the body cavity of the mosquito, and when it ruptures, the sporozoites enter into the hemocoel of body cavity, from where some sporozoites move to the salivary glands. The mosquito is now infective, and when it feeds on humans, the sporozoites are injected into the skin capillaries to initiate the human infection. Till now we have covered two life stages of the Plasmodium species. One is schizogony that occurs in humans and another is sporogony which occurs in mosquitoes. Now we will discuss more about Plasmodium vivax. It has the widest geographical distribution extending through the tropics, subtropics and temperate regions. It is believed to account for 80% of all malaria infections. It is the most common species of malarial parasite in Asia and America but is much less common in Africa. It causes benign tertian malaria with frequent relapses from the hypnozoites, which are the latent forms that establishes in the liver. The merozoites of Plasmodium vivax preferentially infect the reticulocytes and young RBCs. All stages of parasite can be seen in the peripheral blood smears, including the ring forms, amoeboid forms and schizonts. The degree of parasitemia is not generally heavy, each infected red cell usually having only one trophozoite, and not more than 5% of red cells are infected. The ring form is well defined with a prominent central vacuole. One side of the ring is thicker and the other side is thin. Nucleus is situated on the thin side of the ring, giving a signet ring appearance. The ring is about 2.5 to 3 micrometer in diameter, about a third of the size of an erythrocyte. The cytoplasm is blue and the nucleus is red in stained films. The ring develops rapidly to the amoeboid form and accumulates malaria pigment. The infected erythrocytes are enlarged and show red granules known as Kuffner's dots on the surface. These are believed to be the antigens released by the Plasmodium parasite. The trophozoite is actively motile, amoeboid form as indicated by its name vivax. Within each cycle, several rounds of DNA replication produces multinucleate forms called schizonts that undergo segmentation to form daughter merozoites. The schizont appear in about 36 to 40 hours. It occupies the whole of enlarged red cell. The schizont matures in the next 6 to 8 hours with the development of merozoite, each with its central nucleus and surrounding cytoplasm. The pigment granules agglomerate into a few dark brown collections at the center, and with the merozoites around it, this stage presents a rosette appearance. There are about 12 to 24 merozoites per schizont. Erythrocytic schizogony takes approximately 48 hours. The red cell, which now measures about 10 micrometer in diameter, is heavily stippled and often distorted. It bursts to liberate the merozoites and pigment. The pigment is phagocytized by the reticuloendothelial cells. The merozoites measure about 1.5 micrometer and have no pigment. Gametocytes appear early, usually within 4 days after the trophozoites first appear. Both male and female gametocytes are large, nearly filling the enlarged red cell. The macrogametocyte has dense cytoplasm staining deep blue and a small compact nucleus. The microgametocyte has a pale staining cytoplasm and a large diffuse nucleus. Pigment granules are prominent in the gametocytes. Another malaria species about which we must know everything is Plasmodium falciparum because it causes the most severe form of malaria. The name Falciparum comes from the characteristic sickle shape of the gametocytes of this species. This is highly pathogenic of all the Plasmodium and hence the name malignant tertian or pernicious malaria for its infection is given. The disease has a high rate of complications and unless treated is often fatal. The species is responsible for almost all deaths caused by malaria. The Plasmodium falciparum can infect all RBCs irrespective of their age and so the population of red cell affected is very large. The tissue phase consists of only a single cycle of pre-erythrocytic schizogony. No hypnozoites are seen in it. The mature liver schizont releases about 30,000 merozoites. The early ring form in the erythrocyte is very delicate and tiny, measuring only 1/6 of the red cell diameter. Rings are often seen attached along the margin of the red cell. Binucleate rings are common, resembling stereo headphones in appearance. Several rings may be seen within a single erythrocyte, whereas in Vivax there is only one parasite. In course of time, the rings become larger, about a third of the size of red blood cell. The subsequent stages of asexual cycle, late trophozoite, early and mature schizonts are not seen in the peripheral blood smear except in very severe malaria. The presence of Plasmodium falciparum schizont in peripheral smears indicate a grave prognosis. The mature schizont is smaller than in any other species and has 8 to 24 merozoites. The erythrocytic schizogony takes about 48 hours or less, so that the periodicity of febrile paroxysm is 36 to 48 hours. Very high intensity of parasitization is seen in falciparum malaria. In very severe infections, the rate of parasitized cells may even be up to 50%. The infected erythrocytes are of normal size. They show 6 to 12 coarse brick red dots which are called Morer's clefts. Some red cells show basophilic stippling also. Gametogony begins after several generations of schizogony. Gametocytes are seen in circulation about 10 days after the ring stage first appears. The early gametocytes seldom appear in peripheral circulation. The mature gametocytes which are seen in the peripheral smears are curved oblong structures described as crescentric, sickle, sausage or banana shaped. They are usually referred to as crescents. Falciparum crescents can survive in circulation for up to 60 days, much longer than in other species. Gametocytes are most numerous in the blood of young children 9 months to 2 years old. They therefore serve as the most effective source of infection to mosquitoes. The late-stage schizonts of Plasmodium falciparum secrete protein on the surface of RBCs to form knob-like protuberances in erythrocyte cell membrane. These knobs produce specific adhesive called Plasmodium falciparum erythrocyte membrane protein 1 so that infected RBCs become sticky. The infected RBCs stick inside and eventually block capillaries and venules. This phenomena is called cytoadherence. At the same stage, these Plasmodium falciparum infected RBCs adhere to uninfected RBCs to form rosettes. This process of cytoadherence and rosetting causes capillary plugging and decreased microcirculatory flow in vital organs like brain, kidney, lungs, spleen, intestine, bone marrow and placenta, resulting in serious complications. Cerebral malaria is the most serious complication seen in falciparum malaria. It results due to plugging of brain capillaries by the sequestered parasitized RBCs, leading to vascular occlusion and cerebral anoxia. Now coming to Plasmodium malariae. This was the species of malaria parasite first discovered by Laveran in 1880 and the name malaria is the one given by him. It causes Quartan malaria in which febrile paroxysms occur every 4th day with 72-hour interval between the bouts. The disease is generally mild but is notorious for its long persistence in circulation in undetectable levels for 50 years or more. Chimpanzees may be naturally infected with Plasmodium malariae and may constitute a natural reservoir for Quartan malaria. Plasmodium malariae occurs in tropical Africa, Sri Lanka, Burma and parts of India, but its distribution is patchy. Pre-erythrocytic schizogony takes about 15 days and each schizont releases about 15,000 merozoites, and hypnozoite forms are not seen with Plasmodium malariae. It preferentially infects older erythrocytes and therefore the degree of parasitization is lowest among all the species. The ring forms resemble those of Plasmodium vivax, although thicker and more intensely stained. The old trophozoites are sometimes seen stretched across the erythrocyte as a broad band. These band forms are a unique feature of Plasmodium malariae. The mature schizont has an average of 8 merozoites, which usually present a roseate appearance. The infected erythrocytes are either normal in size or slightly smaller. The gametocytes are circular in shape, occupying almost the whole cell. They develop in the internal organs and appear in the peripheral circulation when fully grown. Now coming to Plasmodium ovale. This parasite produces a tertian fever resembling Vivax malaria but with milder symptoms, prolonged latency and fewer relapses. It is the rarest of all Plasmodia infecting humans and is seen mostly in tropical Africa, particularly along the west coast. The mature liver schizont releases about 15,000 merozoites and hypnozoites are present in this species. The trophozoites resemble those in Vivax malaria but are usually more compact with less amoeboid appearance. Schuffner dots appear earlier and are more abundant and prominent than in Vivax infection. The infected erythrocytes are slightly enlarged. In thin films, many of these present an oval shape with fimbriated margins. This oval appearance of the infected erythrocyte is the reason for the name ovale given to this species. The schizonts resemble those of Plasmodium malariae, except that the pigment is darker and the erythrocyte is usually oval with prominent Schuffner dots. The gametocytes are also oval in shape in this species. In the endemic areas, it is not uncommon to find mixed infections with 2 or more species of malaria parasite in the same individual. Mixed infection with Plasmodium vivax and Falciparum is the most common combination, with a tendency for one or the other to predominate. The clinical picture may be atypical with bouts of fever occurring daily. Diagnosis may be made by demonstrating the characteristic parasitic form in the thin blood film smears. Now we'll discuss the clinical features of benign malaria. Benign malaria is milder in nature, can be caused by all 4 species. It is characterized by a triad of fever, anemia and splenomegaly. Fever comes intermittently depending on the species. It occurs every 4th day for Plasmodium malariae and every 3rd day for other 3 species. It coincides with the rupture of RBC schizonts and release merozoites into the bloodstream at the end of each RBC cycle. Each paroxysm of fever has 3 stages. Cold stage that lasts for 15 minutes to 1 hour and the patient feels headache, nausea, intense cold, chills and rigor in this stage. Next is hot stage, in which the patient develops a high-grade fever and dry burning skin. Headache persists but nausea diminishes in this stage. Next is the sweating stage, in which the fever comes down with profuse sweating. The skin becomes cold and moist. Patient feels relieved and often asleep. This stage lasts for 2 to 4 hours. The classical paroxysm may not be present if there is maturation of generations of parasite at different times. In Plasmodium falciparum, the fever is more irregular or even continuous with marked prostration, headache and nausea. Another clinical feature is anemia. Anemia in malaria is normocytic normochromic type. Various factors causing anemia include parasite-induced RBC destruction during the release of merozoites, splenic removal of both infected and uninfected RBCs coated with immune complexes, which also leads to splenomegaly due to massive proliferation of macrophages that engulf parasitized and non-parasitized RBCs. Bone marrow suppression leading to decreased RBC production. The term pernicious malaria is associated with severe falciparum infection. It is characterized by black water fever, algid malaria, and septicemic malaria. Black water fever is a syndrome characterized by sudden intravascular hemolysis followed by fever, hemoglobinuria, and dark urine. It occurs following quinine treatment to subjects previously infected with Plasmodium falciparum. It has an autoimmune mechanism in which antibodies develop against parasitized and quininized RBCs. With subsequent infection and quinine treatment, there is immune complex formation followed by complement-mediated massive destruction of both parasitized and non-parasitized RBCs. Algid malaria is characterized by cold, clammy skin, hypotension, peripheral circulatory failure, and profound shock. Septicemic malaria is characterized by high-grade fever with the dissemination of the parasite to various organs leading to multi-organ failure. Severe falciparum malaria in adults may lead to non-cardiogenic pulmonary edema, often aggravated by overhydration. It does not usually respond to anti-malarial therapy and mortality rate is more than 80%. Hypoglycemia in falciparum malaria is associated with a poor prognosis and is particularly problematic in children and pregnant women and also following quinine therapy. Renal failure occurs in falciparum malaria due to erythrocyte sequestration in renal microvasculature leading to acute tubular necrosis. It is common among adults, then children. Bleeding or disseminated intravascular coagulation can be seen in falciparum malaria. Patients present with significant bleeding and hemorrhage from the gums, nose, and intestine with or without evidence of disseminated intravascular coagulation. Patients can present with severe jaundice. More common among adults than children, it results from hemolysis, hepatocyte injury, and cholestasis. They can also have severe normochromic normocytic anemia characterized by hematocrit of less than 15% or hemoglobin level of less than 5 gram per deciliter with parasitemia level of more than 105 per microliter. Acidosis is the result of accumulation of organic acids like lactic acid. Tropical splenomegaly syndrome is a chronic complication of malaria. It is also called as hyperactive malarial splenomegaly that occurs in malaria endemic areas in tropical Africa and Asia, including India. It results from an abnormal immunological response to repeated malarial infections and is characterized by elevated IgM due to polyclonal lymphocytic activation and massive splenomegaly. Patients respond well to anti-malarial chemoprophylaxis. Quartan malarial nephropathy is a chronic complication seen with Plasmodium malariae. It occurs due to injury to the renal glomeruli by the immune complexes resulting in nephrotic syndrome. Malaria-induced severe immunosuppression in African children provokes Epstein-Barr virus infection to develop Burkitt's lymphoma. Coming to malaria in special situations, first is transfusion-transmitted malaria, which is common in endemic areas. It can be transmitted by blood transfusion, needle stick injuries, or organ transplantation. The clinical features and management of these cases are same as that for naturally acquired infections, but differs in many other ways. Since the infection is being acquired through the infected RBCs and not the sporozoites, there is no pre-erythrocytic stage resulting in shorter incubation period. Also, there is no hypnozoite formation and therefore no relapses. Another special situation is malaria in pregnancy that increases the risk of fetal distress and can result in premature labor, low birth weight, and stillbirth. In areas with high malaria transmission, pregnant women are particularly vulnerable to severe anemia, hypoglycemia, and acute pulmonary edema. Nearly 1 million children die of falciparum malaria each year in endemic countries. Certain complications are relatively common among children like convulsions, coma, hypoglycemia, metabolic acidosis, and severe anemia, whereas other complications like jaundice, acute renal failure, and acute pulmonary edema are unusual in children. Immunity against malaria. Both innate and acquired immunity contribute to the resistance against malaria. Innate immunity refers to the inherent mechanisms of host resistance against malaria parasite. This depends upon various factors. First is the age of RBCs. Plasmodium vivax and ovale attack the young RBCs and reticulocytes, whereas Plasmodium malaria attacks older RBCs, thus restricting the degree of parasitemia to less than 5%. Plasmodium falciparum, on the other hand, attacks RBCs of any age and therefore causes severe malaria. Nature of hemoglobin determines immunity against malaria. Sickle cell disease, hemoglobin C and E, fetal hemoglobin and thalassemia hemoglobin are resistant to falciparum malaria. The protection mechanism include impaired parasite development in RBCs, reduced cytoadherence of infected RBCs, tolerance to malaria infection related to heme catabolism by heme oxygenase, or accelerated acquisition of immunity. Hereditary ovelocytosis. In this condition, the rigid RBCs are less deformable and are resistant to falciparum malaria. RBCs with G6PD deficiency are resistant to falciparum malaria by inhibition of parasite multiplication due to enhanced phagocytosis of parasitized RBCs. The Duffy blood group antigens present on the RBC membrane act as receptors for Plasmodium vivax. So people with Duffy negative RBCs, for example West Africans, are resistant to Vivax malaria. Age and nutrition. Children are more prone to infection and complication. However, newborn are protected from falciparum malaria because of high concentration of fetal hemoglobin in first few months of life. Whereas nutritional status has a paradoxical effect. Severe malaria is rare in children suffering from malnutrition. Now moving on to the acquired immunity. Both cellular and humoral immunity contribute to the resistance against malaria infection. Humoral immunity. Circulating antibodies against asexual forms give protection by inhibiting the RBC invasion and sequestration, whereas antibodies against the sexual form helps in reducing the transmission of malaria. Cell-mediated immunity also plays a role in providing protection against malaria. Cytokines released from the T cells stimulate the macrophages and also stimulate the B cell to produce antibodies. Preimmunization refers to the immunity against Plasmodium that lasts till the original infection remains active, which prevents further infection. This is called preimmunization or infection immunity or concomitant or incomplete immunity. Moving on to the diagnosis of malaria. Malaria can be diagnosed using various microscopic and non-microscopic tests. Microscopy can be done using the peripheral blood smear, which is the gold standard test for diagnosis of malaria. Thick smear is more sensitive for detection of malaria and thin smear help in speciation. Other tests that can be used are fluorescent microscopy and quantitative Buffy coat examination. Non-microscopic tests are antigen detection test, culture-based test using RPI-MI 1640 media, and molecular diagnosis by PCR targeting the 18S ribosomal DNA. Peripheral blood smear still remains the simple and gold standard confirmatory test for detection of malarial parasites. Specimen taken is peripheral blood collected from the earlobe or by finger prick in older children and adults and from the great toe in infants. Blood films should be prepared directly from the capillary blood. In case of anticoagulated blood, smears should be made within an hour of collection of the blood. Time for taking blood sample. Blood should be collected few hours after the height of paroxysm of fever and before taking antimalarial drugs. Parasite density is maximum during this period. Smears should be examined at least twice daily until parasites are detected. Types of peripheral blood smear. It is of two types, thin and thick smear. Both the smears are made at the same time from the capillary blood, either on the same or different slides. At least 2 thick and 2 thin smears should be made. For thick smear, a big drop of the blood is spread over 1 to 2 cm square area on a clean glass slide. The thickness of the film should be such that it allows newsprint to be read through it. For thin smear, a small drop of blood is taken on the corner of a slide. It is spread by another spreader slide at an angle of 45 degree and then is lowered to an angle of 30 degree and is pushed gently to the left till the blood is exhausted. The surface of the good thin film is even and uniform, and it consists of a single layer of RBCs. It forms a feathery tail end near the center of the slide, and margins of the film do not touch the sides of the slide. The smears are stained with one of the Romanowski stains such as Leishman, Ginza, Field, Wright or JSV. Both the smears are examined. The thin smear is screened near the feathery tail end. At least 200 to 300 oil immersion fields should be examined before the smears are considered as negative. Advantages is that peripheral smear is simple, rapid and cheap. Thin smear is used for the identification of species of malaria parasite, but it is labor intensive and requires experienced microscopist. It also has low sensitivity. The detection limit is more than 200 parasites per microliter of blood. Thick smear is used for detecting the parasites and it is 40 times more sensitive than the thin smear. It can detect 5 to 10 parasites per microliter of blood. The speciation of malarial parasite by thin smear is based on the detection of the ring forms, trophozoites, schizonts, gametocytes, RBC size and pigment. Parasitized RBC is normal in size and shape for Plasmodium falciparum and malariae. It is enlarged for Plasmodium vivax, whereas for Plasmodium ovale, RBCs are enlarged with fimbriated margin. We can identify different species based on the number of merozoites present per schizont. For example, in Plasmodium vivax, schizont is large, 9 to 10 micrometer, completely fills the enlarged RBC and contain 12 to 24 merozoites per schizont. In Plasmodium malariae and Plasmodium ovale, schizont is small, about 6 micrometer, fills 3/4 of the RBC and contains 8 merozoites per schizont. In Plasmodium falciparum, schizonts are not seen in the peripheral smear. Gametocytes. In Plasmodium falciparum, the gametocyte is crescentric or banana shaped and larger than the RBC, whereas for other species it is spherical and almost occupies the RBC. Now, how do we identify different species based on ring forms? It is the most important form that helps in accurate speciation. It comprises of a vacuole in the center, peripheral thin rim of blue cytoplasm surrounding the red nucleus. In Plasmodium falciparum, rings are 1.5 micrometer in size, smaller than that in the Plasmodium vivax, occupying 1/6 of the RBC, and 3 variants of these ring form may be seen in Plasmodium falciparum. First is the multiple ring forms are seen inside the same RBC. Ecole form, that is the ring form attached to the RBC membrane. Third is the double dot or the headphone shaped ring form. It has fragmented nucleus. In Plasmodium vivax, rings are 2.5 micrometer in size, occupies 1/3 of the RBC. Cytoplasm opposite to the nucleus is thick. Late trophozoites are amoeboid shaped. In Plasmodium ovale, ring forms are similar to that of Plasmodium vivax but present inside oval shaped RBC. In Plasmodium malariae, early trophozoite is similar to that of Plasmodium vivax but late trophozoite is band shaped, also called band forms. Coming to quantification of parasites. Thick smear is preferred to thin smear for quantification of parasitemia. The quantification is done by calculating the number of parasites counted compared to the number of white blood cells in thick smear. And in case of thin smear, number of parasites are compared to the number of RBCs in the thin smear. Quantification is helpful for assessing the severity of infection, monitoring the response to the treatment, and detecting drug resistance of Plasmodium falciparum. Fluorescent microscopy is a fluorescent staining technique for demonstrating malaria parasite. Blood smears are prepared on a slide and are stained with acridine orange and examined under a fluorescent microscope, and the nuclear DNA is stained green in this. Another important method of examination is quantitative Buffy coat examination. It is an advanced microscopic technique for malaria diagnosis. It consists of 3 basic steps. First, 60 microliter blood is collected in a QBC capillary tube coated internally with acridine orange. It also contains a precision float. Second, the capillary tube is centrifuged, which causes separation of the components of blood according to their densities, forming discrete layers as RBCs, WBCs, lymphocytes, and platelets. Finally, examination of the capillary tube at the Buffy coat region under ultraviolet light source. Acridine orange has a property of staining the nuclear DNA fluorescent brilliant green. Normal RBCs don't take up the stain as they are anucleated. However, parasitized RBCs appear as brilliant green dots. WBCs also take up the stain. Advantages of quantitative Buffy coat is that it is faster, the entire tube can be screened within minutes, it is more sensitive, at least as good as thick film, and quantification is also possible in this. Disadvantages are it is expensive, less specific, and speciation is difficult. Now coming to rapid diagnostic tests. Several malarial antigens can be detected. Parasite lactate dehydrogenase is produced by all Plasmodium species. Currently available test kits can differentiate Pan LDH common to all species and Plasmodium falciparum LDH specific to Plasmodium falciparum. Parasite aldolase is produced by all Plasmodium species, while histidine-rich protein 2 is produced only by Plasmodium falciparum. Principle of the test is, test kits currently available use a nitrocellulose membrane strip with 2 parasite detection lines and a control line. Test line 1 is coated with captured antibodies specific for Plasmodium falciparum, for example, histidine-rich protein 2 or Plasmodium falciparum LDH. Test line 2 is coated with captured antibodies common to all Plasmodium species, for example, Pan LDH or aldolase. Procedure: drop of blood specimen is added along with a buffer solution to the sample window, and malarial antigen combined with polyclonal malarial antibody labeled with colloidal gold present in the buffer and move along the nitrocellulose membrane to meet its corresponding antibodies at different test lines. Interpretation is based on immobilization of malaria antigen at test line 1 and or 2 forming colored bands. If band is formed at test line 1 only, it indicates Plasmodium falciparum infection. If band is formed at only test line 2, it indicates Plasmodium species other than Plasmodium falciparum infection. If bands are formed at both test lines 1 and 2, it indicates Plasmodium falciparum or mixed infection. The band at control line must come to validate the test. If it does not appear, test is considered invalid. Control line is coated with antibody against polyclonal malarial antibody present in the buffer. Now let us compare various diagnostic methods, that is peripheral smear, QBC and RDTs. Methodology for peripheral smear is cumbersome, whereas it is easy for QBC and RDT. Time required is 60 to 120 minutes for peripheral smear and it is 15 to 30 minutes for both QBC and RDT. Sensitivity for peripheral smear is 5 parasite per microliter in thick smear and 200 parasites per microliter in thin smear. For QBC, it is as sensitive as the thick film, whereas in RDTs, more than 100 parasites per microliter are required to provide more than 90% sensitivity. Specificity: peripheral smear is the gold standard, whereas QBC and RDTs can give false positives. For speciation, peripheral smear is accurate and as it is a gold standard. For QBC, it is difficult. In case of rapid diagnostic test, it detects Plasmodium falciparum but cannot differentiate non-falciparum species. Cost-wise, peripheral smear is inexpensive, QBC is costly, and rapid diagnostic tests are also inexpensive. For peripheral smear, experienced microscopist is required, whereas that is not required in QBC and RDTs. Various molecular tests have recently gained attention for malaria diagnosis. Nested multiplex PCR targeting 18S ribosomal DNA has been developed for detection of all 5 human malarial parasites including Plasmodium knowlesi. PCR can also be used to detect drug-resistant genes. Real-time PCR is useful for quantification and speciation of parasites. Automated systems include parasite F digital cytometry and automated microscopy methods that have recently been developed for rapid detection of malaria parasites. Other non-specific tests include normocytic hemolytic anemia, leukopenia, metabolic acidosis, raised ESR, and hypoglycemia. Coming to the treatment part, treatment of Vivax malaria is chloroquine tablet given according to the weight over 3 days as shown in the table. In addition, primaquine is given for 14 days to kill the latent hypnozoites in the liver. Primaquine is however contraindicated in infants, pregnant females, and G6PD deficiency. Falciparum malaria is treated differently in northeastern states and rest of the states. For uncomplicated falciparum infection, we use 2 oral agents in combination so that the resistant forms do not emerge. In the northeast, we give artemether plus lumefantrine, whereas in other states we give artesunate plus sulfadoxine pyrimethamine combination for falciparum. We also give primaquine to all the falciparum patients on day 2 as a gametocidal agent so that the chances of transmission is reduced significantly by killing all gametocytes in the blood. For pregnant females, we give quinine, and for mixed infection, we add primaquine for 14 days to eradicate the latent hypnozoid forms. Severe malaria is invariably caused by falciparum and we use intravenous or intramuscular agents for its treatment. Oral drugs are not very effective for severe malaria. IV artesunate, IV quinine, IM artemether and IM arteether are used for the treatment of severe malaria. Antimalarial drug resistance has emerged as one of the greatest challenges facing malaria control today. Drug resistance in falciparum malaria. It is widespread and is described against several antimalarial drugs. However, there are geographical variations. It is concentrated mainly in the Southeast Asia. The factors that contribute to emergence of resistance are longer half-life of drug, mutation in the parasite gene, inadequate and irregular usage of drugs, and host immunity. Drug resistance in Vivax malaria. There are several cases of resistance to chloroquine that has been reported in some areas of India, Burma, Indonesia, Africa, Brazil, and few others. Guidelines for assessing the degree of resistance. Antimalarial drug resistance is detected by in vivo and in vitro methods. In vivo method, the degree of resistance is assessed based on 2 factors, that is persistence of clinical manifestations and level of parasitemia following administration of antimalarial drug. In vitro tests. Various in vitro methods are also available for antimalarial drug susceptibility testing, such as the WHO in vitro micro test using RPMI 1640 medium, ELISA for measurement of HRP2 or LDH, PCR to detect the Plasmodium falciparum specific drug resistant genes. Chemoprophylaxis is recommended for travelers, migrant laborers, and military personnel exposed to malaria in highly endemic areas. For short-term chemoprophylaxis, that is less than 6 weeks, doxycycline is recommended at a dose of 100 mg daily. The drug should be started 2 days before travel and continued for 4 weeks after leaving the malaria endemic area. Long-term prophylaxis, that is for more than 6 weeks, mefloquine is recommended at a dose of 5 mg per kg weekly and administered 2 weeks before, during and 4 weeks after leaving the area. Coming to vaccine, the only approved malaria vaccine is RTS-S, known by the brand name Mosquirix. As of April 2022, the vaccine has been given to 1 million children living in areas with moderate to high malaria transmission. It requires at least 3 doses in infants by age 2, with the 4th dose extending the protection for another 1 to 2 years. The vaccine reduces hospital admissions from severe malaria by around 30%. Research continues with other malarial vaccines. The other most effective malaria vaccine in the pipeline is R21 Matrix M with 77% efficacy rate shown in initial trials and significantly higher antibody levels than with RTS-S vaccine. It is the first vaccine that meets the WHO goal of malaria vaccine with at least 75% efficacy. So that was all about malaria. Hope you liked the video. Please like, subscribe, share and comment. Keep watching and supporting my channel.